Welcome to the AUA News Inside Track podcast, an official podcast of the American Urological Association. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.
I am Dr. Andrew Harris, Chair of the American Urological Association's Quality Improvement and Patient Safety Committee. This is part 2 of 4 of our Quality Improvement Project Guide podcast series. In episode 1, we introduced the project guide and highlighted some key QI methodology. Today, we're going to talk about the planning phase, where strong preparation can set a project up for success. I'm here today with Dr. Marty Koyle, Adjunct Professor, University of Minnesota School of Medicine, and Dr. Kara Watts, Vice Chair of Urology at Montefiore. Thank you both for being here today.
Great to be here.
Looking forward to having this discussion with you all about the planning phase of quality improvement and the PDSA cycle. So really learning how we get off on the right foot. And so Marty, let's start with you. In your experience, where do these QI project ideas usually come from? And how do you know if it's a good idea of something that you want to chase?
So I think the big thing, Andrew, is that QI projects are often gut feelings where you as an individual find something that just doesn't seem right, or you think you could do a little bit better than what's being done either in your institution or in your own setting. The key is really to make sure it's something that's focused. So you want to be able to scope things down to a level that you truly understand the problem and understand it's within your realm for you to solve. You're not going to solve world poverty and world hunger. And the thing really has to be something that's under you and your team's influence.
Yeah, and I think the only other thing I would add to that is a really good QI project is something that is applicable to something more than just one person or one sort of micro-focused surgical outcome. It has to be broadly applicable enough that there's some value in putting your time and efforts into it. And you have to think about really being able to obtain the data to look at what you want to improve. If you want to improve something, but your question and your way of going about it requires data that you just don't have a way of obtaining, you're not going to have a successful project.
Those are great points, Karen. You know, I think one of the confusing things for people who start out on QI projects, when they think of a problem, they don't understand the difference between quality improvement and quality control and quality assurance. And what I like to do is explain to them that quality control, for instance, is knowing you have enough sinks in the environment to wash your hands. Quality assurance is making sure that the water is running with appropriate levels of hot and cold temperature. But what quality improvement truly is making sure that people actually wash their hands, if that makes sense.
I think that makes total sense. I love it in a very simple sense.
Yeah, I appreciate both of your thoughts and input. I also find sometimes some of the best QI project ideas can come from talking with people in the environment in which you work about what's frustrating in their daily environment. If we have long wait times in the clinic because our clinics are inefficient, turnover times in the operating room often resonates with many of us. And really, what are those pebbles in the shoe that make it hard for us just to show up and do our job? A lot of times that may give us an idea of something that, you know what, we should take a little bit more in-depth look here and see if it really is a problem. And then I think to your point, Kara, how do you measure it, right? And so it's really hard to solve problems from behind a computer screen, but sometimes some of our automated data can at least give us a signal that we should go look somewhere to see if we can make it better. Like if one of our metrics like turnover time is high, we may not know why it's high, but we know it's high. And then we can go look and see, what are opportunities for improvement there. And I think that helps us sometimes know if it's a good idea, because there's plenty of things that we can try to fix, right? But not all of them do we need to go after and fix. Or some of them may require a whole lot of work, but we're not going to get a whole lot of fix out of the work that we're going to do. And so really, how do we, like you were saying, Marty, how do we scope that to something we can control and that we know we'll get a lot of bang for our buck? So I appreciate your all's thoughts there. And talking about how we further understand if this is a good idea for an intervention, along the lines you were speaking, Kara, there are a lot of tools out there, process maps and fishbone diagrams and Pareto charts, all really helping us better understand the problem we're trying to tackle. I think a lot of people would probably also say the planning phase is among the most important in the improvement cycle. So how do you decide which ones of these tools to use?
All of these charts or tools are very visually driven. So there are just different ways of sort of exploring data or presenting data. And so some of them have very specific purposes, and it depends on which phase of the project you're in. But for the planning or sort of discovery phase, a fishbone diagram is really great for looking at all of the different contributors that can lead to the outcome that you're trying to change, and even the sub-component parts of each of those branch contributors that also lead to the branches leading to the outcome. So it's good for sort of brainstorming and figuring out where within each of those little areas you may be able to work on or perhaps gather data from. A Pareto chart is really once you start to get numbers and data from. So if you want to really map something out, see all of the different variables that contribute to the outcome, but you actually have numbers and objective data to put to that to see what are the most frequent or the most often factors that are contributing to what you want to work on. So you need to have data to actually be using a Pareto chart. And otherwise, process map is actually one of my favorite ones to use because it's getting from point A to point B. And point A, if you take a simple idea of, I want to get to work earlier. And that's from leaving your door to arriving at work. And a process map is all of those different things that happen or can happen between point A and point B, and all of the different things that can affect that and where you may be able to work on or implement some changes. So it's a really great visual display that can bring in a lot of outsiders' input or your own input to figure out where you may be able to start working on for making changes.
So I think Kara really hit the nail on the head. I think that we use different tools, and there's many different tools, not just the ones that Kara discussed. But if you're going to start doing QI yourself, you have to realize that you have to understand the problem and why it might be happening before you choose an intervention. And that's why the fishbone or Ishikawa diagram is so helpful. And what I often do is when I first start with them is keep it simple with just four ribs that I call the 4 Ps: people, places, procedures, and policies. I think, again, you're absolutely right with how important the Pareto relies on having data already so you can really prioritize where you're going to lead your interventions. And once you've focused on the problem and have a possible intervention, then you have to really understand the process completely. And that's why the process map to me is the absolute mandatory tool in your toolbox that you have to utilize to really understand what's going on in the process itself. And remember, you don't want to have the final product. You want to start in the process map with what's in real time and happening, not what you intend to accomplish at the end of your intervention.
I think that's such great context, Marty. And, I would imagine that some people in residency programs or listeners are already doing this and perhaps don't even realize it. We use fishbone diagrams for M&M. So if you have an untoward or a surgical complication, we present it with a fishbone diagram with exactly as you said, the people, the place, the policy, and what are the components of that may have led to that surgical complication, and where could there be an opportunity for improvement. So some people may very well be doing this even on very small scales on a semi-regular basis and not be aware that these are intentional QI reviews, QI projects.
I appreciate both your comments. Yeah, you're talking about the fishbone diagram, just a wonderful way to understand the various contributors to an outcome that you're examining, which you mentioned, Kara, and you too, Marty. Also may give you an idea of what you want to measure in the Pareto chart. All right, the different things that you see going wrong as part of the root causes or contributing issues to what process you're examining. I love process maps. I love to watch a process and map it out and then talk to people about what they think the process is supposed to be, because often what we think the process is supposed to be is not what we actually do. And that tends to be fairly powerful in a group setting to get people to understand how we have opportunity for improvement. So appreciate your thoughts there. So it sounds like we have some different tools. Each has a little different use, right? And so a lot better to use the correct one in the correct setting. So appreciate you all discussing those. And for our listeners, those will be in the AUA QI project guide. You can take a look at examples of each of those tools. So moving on to our next topic, stakeholder engagement in building a team can often make or break a project. So how do you figure out who needs to be involved early on, and really what's going to make a good QI team? Marty, you want to start with this one?
Sure. I think the key to having a good team is one that is going to be committed to attending meetings and be involved and open their mouths on behalf of the stakeholders that you ultimately hope to be your audience for your project. I think the key is not to make it too big or too small, and to make it diverse enough. So in general, a good starting point for a team is around 6 to 8 people. It may include colleagues, it may include managers, it may include patients even on your team. And you can always use consultants from time to time, but the key is to make sure that you have the consistency with that core group that's going to attend every meeting and not be afraid to open their mouths from time to time.
Yeah, a really simple rule of thumb that my QI instructor taught me was the 2 pizza rule. The core team should be able to sit around a table at lunch and have 2 pizzas and everybody get fed. And those are the real committed people making up the core team. If you have too many people, then not everybody will feel as engaged or contribute equally. And if you have too few, it may not be enough or enough distribution of people or backgrounds to really make the project successful.
I appreciate both your thoughts, and I think some takeaways there are, making sure to create an environment that is safe for people to speak. And I think we all have opportunities to do better in those areas. I know for me, it is sometimes challenging because in the operating room, we communicate very directly and very expectantly. And that doesn't work so well in a group when you want to get good ideas to come up to the table and make sure everybody feels safe talking. So I think as surgeons, at least some of us, me included, have to be very careful when we're in these meetings to make sure it's a place where people feel safe to speak. So the best ideas do come up to the top of the table. And I think that your discussion about how many people is important, but also who needs to be there. I think if you get a bunch of leadership people in a room as your committed core who don't actually do whatever process you're trying to change, you're going to struggle because they don't understand the work. And so making sure that you have people in the team that understands the work is really important. And so a good mix of frontline stakeholders, as well as people who can help influence the change, are going to be important. Like Marty said earlier, making sure that you have it scoped appropriately so we have some control, which is going to take some leadership buy-in, but also making sure we have people there at the table who understand the work that we're trying to change.
Yeah, I think you hit a point there too, that in essence, what you're saying, Andrew, is that the people you're choosing are essentially champions, and they're representing the stakeholders that you want to impact in the long term.
Well, it's hard to follow after that final statement there. I was going to say, there can be a distinction between sort of the core team, right? The team that's going to sit around the table, have the 2 pizzas to split, really be the thought engine behind this and the boots on the ground, working together with the data. But there can be the higher up leader or the sponsor, the real high champion, if you will, that does not have to necessarily be at every single meeting, but have the ability to affect the change at a higher level that you may need to be able to be successful in your project. So if you want to make a change in the OR, for example, you may need to have an OR leadership individual available, and they may not be able to sit at every meeting with you, but they need to be part of your sort of peripheral team and have buy-in for that. Or, clinic management, some higher level individual to expand the team.
Yeah, so based on this discussion, really making sure the right people are involved is key to success. So appreciate your thoughts and commentary there. So before you start making any changes, the team needs to set a direction. And there are a couple of different ways to do this. And, you can have SMART goals or SMART aims, and you can also have clear measures. And so why are these steps so critical to a project success, Kara?
So you have to know what you're trying to change and what you actually want to accomplish. And so if you just make a generic statement, I want to improve post-op infections for this particular surgery, that's a very vague, non-specific, non-time-bound goal, which, while in line with perhaps what your overall thought is not specific enough to really even know what type of data you want to pull. So that's where the idea of the SMART aim comes from. And the SMART aim, you can see it in our educational guide, is a simple acronym for the 5 components that make up a very simple statement for developing a QI project. And the goal needs to be very specific. It needs to be measurable, something that you can actually obtain data to track. It needs to be achievable. It needs to be something that you can actually do and accomplish. It needs to be relevant. It needs to be relevant to your practice, to your people, to whatever outcome you're trying to improve. And it needs to be time bound, meaning you need to set a time point or goal, a deadline of when you want to accomplish this by, so that the project does not just continue in perpetuity. And this gives the whole team solidified collaborative goals to work toward.
Kara, it's funny. A lot of people claim that QI isn't science, but it's no different than anything else we do in research. We identify something that we think is a challenge. We have a hypothesis, and then we try to do something to try to prove our hypothesis. And the beauty of QI is you don't want to spend a lot of time and effort and money if you don't have to. And that's why we do PDSAs. And PDSAs, which I'm sure Andrew has discussed with our other colleagues, really should be no more than 6 to 8 weeks in general. And what you want to do is use the measures that Andrew brought up to really define how we are doing. Are we meeting those measures? Are we spending too much time doing something else? Do we need to take a step backwards and identifying the problems as they are? So I think without the measures, we're unable to take a next step. And measures, just like the aim, are also SMART driven, just like you said.
A thing I will just add to the PDSA cycle, because it's such a familiar term for people who are learning or engaged in QI projects, is that it doesn't all have to be a forward motion circle. So you can go backwards, you can go forwards, depending on what the measured outcome is, or the data that you're reviewing. So if you do a change and it doesn't make an improvement in the direction that you want to, it's not a failure. It's something to learn from, and the wheel kind of goes back a little bit. But then you make a change and it starts to roll forward again. So it's sort of this back and forth process with ultimate forward motion overall.
I think failure is the beauty of QI. Is everybody thinks that anytime we define a project in QI, that it's going to be an upward trend, just like we hope the stock market's going to be, and it certainly has been doing well lately. But in reality, the market goes up and down, and PDSAs, you're going to find sometimes you do fail, which is not failure. It's an opportunity to do something else.
I appreciate both of your thoughts. Yeah, I like to talk to our teams about really don't fail. We just learn and then change it up the next time. And I think our comments about clear measures, if you're going to allocate a team to do a lot of hard work, and you may be allocating resources, people want to know, are we making a difference? And so making sure that you have clear measures so that the team knows how they're doing is really important. And then if you are going to move and scale and grow through iterative PDSA cycles, that success is going to be very important at the next leadership level to gain resources to help you move forward. So I really appreciate the thoughts today. Really appreciate your all's time, Kara and Marty. Thank you for being with us today. Thank you for the audience for taking time to listen today. We hope that you will take a look at our developed project guide. That wraps up the second episode of our 4-part series on the QI project guide. Be sure to tune into the next 2 episodes where we will talk about implementing, studying, and acting on the results of the intervention.
This has been an AUA News Inside Track podcast. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.